answer to this one is B. All right, the answer to this one is false. And then this is the last one. All right, the answer to this one is true. How'd you do?
Awesome.
Good. Huh? Okay, very good. All right, very good. All right, so we're gonna look at the endocrine system today, and these are really the 4 glands that we'll look at. And we're really gonna look at the medications associated with these glands and not necessarily focusing in on the glands themselves. So we're gonna look at medications that affect the thyroid gland, the parathyroid, our adrenal glands, and the pancreas. So those are the 4 that we'll look at. So the first group of meds are going to be the adrenocortical agents. So these, it says key terms used throughout the chapter. That's not things that I'll use necessarily in class, but as you read and study, you'll see it a lot. So just be familiar with those terms. When we start talking about corticosteroids, we're talking about glucocorticoids and mineralocorticoids. So these adrenocortical agents are typically used to help suppress some kind of inflammatory or immune response. They don't cure whatever the inflammatory response is. They can also be used for like adrenal insufficiency, and usually they're not recommended for long-term use unless someone has a chronic problem, and then even then the medications are adjusted. Can y'all think of a condition that may have the use of steroids?
Asthma.
Asthma, arthritis, right? So we've already talked about some steroid meds. Y'all remember from where?
Respiratory.
Upper respiratory meds. Very good. All right. Let me make sure I didn't forget anything. Bless you. So the diurnal rhythm is kind of similar to like the sleep-wake cycle. So this is the cycle that kind of keeps your body regular. So light during the daytime, night is dark time or darkness. So this affects your sleeping and the things that typically happen in a rhythmic pattern. So, go ahead.
Oh, sorry. Why would you want to suppress the immune system?
So it depends on what's going on with your patient. So that's a good question. We're going to talk about some of those things. Good question. All right, so when we are talking about the diurnal rhythm, the reason that we kind of address it so much with steroid use is because typically when you're giving your patient a steroid, especially if it's once a day, you want them to take it in the morning time. So that way they can kind of keep that same sleep-wake cycle, because your different hormones in the adrenal glands are going to affect your fight or flight, they're going to affect your blood sugar, all those types of things. All right, so the 2 adrenal glands, they're like the hats that sit on top of the kidneys. So they have an adrenal cortex and the adrenal medulla. So the medulla we'll talk about more next semester when we look at the sympathetic nervous system. This semester we're focusing in on the hormones in the cortex. So we're looking at the glucocorticoids, which are more related to sugar, the mineralocorticoids, which are going to be kind of your salts, and then we're not going to focus on the androgens in as detail as we will the glucocorticoids and the mineralocorticoids. So when we talk about the mechanism of action of these meds and what they do, the fact that glucocorticoids are sugar-related and mineralocorticoids are salt-related should start giving you an indication of some of the adverse effects, some of the reasons or people who they should be avoid use in, and that kind of helps you set up how you will study and kind of what you will focus on. Because though the glucocorticoids are more centered in the sugar and that kind of thing, they still can have some mineralocorticoid properties. But when we're studying, we're thinking about the big or the main part of what's going on with your patient, or whatever the question is asking is going to be the big part. So this is in your book. I'm not going to go over it because we've talked about it kind of each lecture. But every time your book says where medication works, this is just a good thing for you to have to remember what's going on where. Some of these meds are going to look familiar because we saw them with our upper respiratory meds. So some of the adverse effects, some of the mechanism of action should be the same or should kind of be familiar. You should kind of bring them forward as we study the endocrine drugs. So the first group of drugs we're going to look at are the glucocorticoids. So they do end in zone for the most part, but some of them don't. So the biggest thing with the glucocorticoids is because you've seen them before, because we're familiar with steroids, you know kind of how they end, but prednisone is the one that we're going to focus on the most. But the whole class of glucocorticoids is what's important. So depending on the route of administration, depending on how long the drug is used, is going to determine how effective or ineffective the medication is. So glucocorticoids are going to stimulate an increase in the glucose levels, and this is important for things that require a lot of energy. So because we're talking about energy, when we start talking about breaking down of proteins, that also plays into the mechanism of action for glucocorticoids. So these drugs bind to receptors that affect inflammation and the immunosuppressive effects. That's the therapeutic action of these drugs, and usually they're indicated for treatment of a lot of inflammatory disorders or to relieve discomfort. So when we start talking about musculoskeletal, people who have osteoarthritis, rheumatoid arthritis, a lot of your musculoskeletal diseases, these patients are on steroid therapy. Anybody who typically has like knee issues, if they get an injection in the knee, it's typically a steroid that they're getting in the knee to help with inflammation and pain. One of the actions that the medications also do is that they block the aracondac acid, which helps to decrease prostaglandins and leukotrienes. Where do y'all remember hearing about prostaglandins? So we heard about them in the lecture about the immune drugs and about the pain medications, and we also heard about them in patho. So what's significant about prostaglandins and how they react or how they relate to the steroids? So they're going to correct. So they're going to work by blocking this release here. So without those chemicals being released, normal inflammation is typically blocked. So even though we haven't had the lecture on endocrine, we've had other lectures that will hopefully kind of bring to mind some of the things that we've already learned. So I'm saying all that to just kind of help us bring it back in because we've seen it, we just got to put it together. All right, so these meds are also helpful in moments where you have inflammation, like people who have allergies, people who have asthma, because of their effect on the inflammatory system and the immune response. These are also used for that. These meds are also used for patients who may have transplant rejections. So remember that can be antibody related. So these drugs are used for those patients as well. And then again, we do use these drugs for adrenal insufficiency. Since we're talking about the adrenal glands, these medications can be used for that as well. So these are absorbed pretty well from a lot of different sites, depending on whether you're given it orally, IV. It's going to depend on where the medication is or how the medication is absorbed. Glucocorticoids are definitely known to cross the placenta and enter the breast milk, so the benefit for that for the female patient has to be greater than the risk. Prednisone is the only drug that's available orally. We don't give prednisone IV, we only give prednisone PO. So that is only available in its oral form. Why would we want to caution use of this medication in people with who are on antibiotic therapy? Go ahead.
Because it suppresses immunity.
Mm-hmm.
So if you're already in antibiotic therapy, you try to fight
Mm-hmm.
pathogens.
Mhm.
If you see it's getting worse.
Yep, so anybody who has an active infection, you want to caution use of steroids. So the exception to that sometimes is in some of your different cancer patients, like you were asking Adelia, sometimes those patients are on steroids even though they're already immunocompromised. Sometimes cancer patients are on steroid therapy for other reasons. So sometimes those are used in those instances too. So for sure, because we're talking about a glucocorticoid, if your patient is diabetic or has hyperglycemia, we want to caution or be very careful about how much and how often we're giving these patients that type of medicine. And then in those with peptic ulcer disease, it's been known that steroids can cause peptic ulcers or cause irritation in the lining of the stomach. So typically you want to caution use in those patients also. So the effects of your steroids, there's a box here, 36.5 in your book. But if we're talking about an oral steroid medication, we're looking at systemic types of reactions or adverse effects. So, I have a hand up. All right. So systemically, hyperglycemia is something that's an adverse effect. So these adverse effects, water retention, edema, weight gain, osteoporosis, these all, you will see those in Cushing's disease. So when y'all study the endocrine system, Cushing's disease is what this looks like. So a lot of times your patients who have Cushing's disease, part of their etiology is that they've been on long-term steroid use. So that is the water retention, edema, the weight gain, osteoporosis of the bone. That is a classic Cushing's patient, with the exception I didn't put the buffalo hump on there, but they have like a fat pad on the back of their neck, and that's a Cushing's patient. Also, like we said, if your patient has peptic ulcer disease or infections, you want to be careful with giving them that medication. Because these are glucocorticoids, we also want to monitor for adrenal insufficiency. And like I said, I know you guys haven't had patho yet, but adrenal insufficiency looks like hypotension, anorexia, and altered mental status. So these patients may have something called Addison's disease. So that's an adrenal insufficiency adverse effect that you will see as well. If your patient is on steroids, we do not abruptly discontinue those medications because we could cause adrenal insufficiency in your patient. So typically these meds are going to be weaned or tapered off over 10 to 14 days. And so if anybody's ever had anybody who's taken steroids, sometimes they can have mood disorders or kind of be a little grumpy or have some different moods. So mood disorders is another thing that steroids can cause also, especially glucocorticoids. So our drug-drug interactions, there are some in your book that we have not had yet, but for the most part, if you have a patient who's on a steroid, what's a potassium depleting agent you might want to caution using? Oh, go ahead, Dee.
So you mentioned Cushing's disease, so would adverse effect just be Cushing's disease as well? It could lead to it?
So for the class, I would just focus on the specific different manifestations and I wouldn't say Cushing's.
Okay.
But if you see that patient and that's what they have and then they're using a lot of steroids, then that would explain that.
Okay.
Mm-hmm. So what's a potassium depleting med that we've had before?
Diuretics.
So our diuretics, right? So loop diuretics, thiazide diuretics, you want to caution your patient's use with that. You don't want to give your patients these medications if they're requiring live vaccines, especially because of the chance for masking any kind of response to having like an allergy or a reaction to that antibiotic, to the antibody, excuse me. And then anticoagulants are always going to be a caution when you're giving your patient glucocorticoids, and really any med. And anticoagulants just don't really mix with anything. So because prednisone is a glucocorticoid, it's mostly going to affect the inflammatory and the immune response. It still has some mineral corticoid effects, but the main response is going to be related to inflammation and to the immune response. When we start talking about the mineral corticoids, that's going to affect more of your patient's fluid volume status. So again, prednisone is only available PO, and the onset varies on the dose. So really the biggest thing that we're looking at is the duration of this med is for like 1 to 1.5 days. So this is why that med has to be tapered off. We can't just abruptly discontinue the medication. Y'all good? Okay. So what are we gonna do for our patient who's on a glucocorticoid? what are some things that we're gonna assess on them? So blood glucose, very good. What else? We'll check potassium levels, what else?
Peptic ulcer disease or GI bleed.
Say what?
Vital signs.
So we're gonna check their health history, good, all right? What are some things that we wanna teach our patient? Go ahead, Molly.
Drink, like if they are drinking, to
Mhm.
limit that while they are taking them.
Okay, so we definitely wanna be concerned with fluid volume status, Stephanie?
Diarrheas
Okay,
and diuretics and
Mhm.
medication corrections
okay,
and repeated ibuprofen.
okay, so
Already.
NSAIDs, okay, very good, all right, V, oh, go ahead, sorry, go ahead, V.
We'll monitor the potassium intake.
So we'll monitor their potassium intake. When are they gonna take this medication typically? In the morning time, all right? So what if I have acute, like what if I just got diagnosed with pneumonia and I'm on a whole bunch of steroids and it's making me feel kind of moody and crazy and I just wanna stop taking
You
them?
can't abruptly stop
So can abruptly stop, why?
because it can.
So what can that lead to? Adrenal insufficiency, because we're talking about adrenal gland specific hormones and medications. Very good. Go ahead, Sarah.
Topical use.
You said the topical?
Yeah.
Mhm.
Like, you usually done everything, or it's not the same?
No, so a lot of times people put on like topical steroids and they just glob it on there, right? They just rub it on there. But you have to apply the dose that's recommended on the tube, because you still can, even though it's a topical, like a local, if you put too much, you still can have systemic responses. Go ahead, Jeremy.
Going back to like the teaching them, would you wanna, like, besides, I guess, for the, does it make it more likely for them to have Cushing disease?
So more on long term.
Long term?
Yes, so if somebody's taking it for a long time, yes.
Do you monitor that by
Mhm. So you monitor blood pressure, you monitor fluid status, you'll monitor, intake and output, that kind of thing.
No live
And
viruses.
you'll notice, like you will notice if the patient starts to, because basically they have a big belly, they have buffalo hump, and they have very small legs with like bruising all over it. And then yes, the live viruses. Okay, very good. All right, so across the lifespan, children typically do not get a lot of steroids because steroids tend to diminish or stunt or block growth in children. So they're not always given steroids. They have to be given steroids for a specific reason. So sometimes adults may have steroids when they have respiratory issues, but kids not so much unless it's like asthma or something like that. For adults, again, we mentioned about the importance of when to take the medication. And of course, for your older adults, we always want to be concerned with hepatotoxicity and nephrotoxicity, because the more the medication accumulates in the body, the more difficult it is to metabolize and to excrete it. So especially when we talk about the mineral corticoids, we're going to be concerned with fluid levels and with retention. So aldosterone is that main mineral corticoid. And where else have y'all seen aldosterone? The RAS system, right? So aldosterone helps you to retain water and sodium. So because of that, these medications, even though they're mostly mineral corticoids, they do have some glucocorticoid properties also. So typically these medications, like we said, they're gonna help reabsorb sodium in the kidney tubules, and they're gonna help increase potassium excretion and sodium and water retention. And these meds a lot of times are given when you want to increase volume in your patient. And fludrocortisone, which is our med of choice, this is a lot of times given for patients who are hypotensive. So they can get that med for hypotension or for replacement. This med is absorbed pretty slowly and is distributed throughout the body. Your patient who's on this medication, they also could be on a glucocorticoid, but the benefit of that has to outweigh the risk. So typically, because it's such a strong mineral corticoid, do you really want to monitor your patient's blood pressure and fluid volume status a lot? Oh, there we go. So there we said it. All right, so avoid in patients who are hypertensive or who have heart failure because of the extra effects that it could have on the volume related to the heart and the blood pressure. With these medications, if they're taken together, They're mostly to help with inflammation and immune response and not necessarily for fluid volume. So like I said, the benefit has to outweigh the risk of why the two would be used together, because typically you don't combine both of them. Go ahead.
So the fluorocortisone,
Mhm.
it's not a glucocorticoid too.
No, it's a mineral, but it has small properties. It's a mineral corticoid. But it still can have some glucocorticoid properties if you combine it with the other.
So for I have that
Mhm.
glucocorticoid properties as well, and combine with
Correct.
Or they already, because like hypercortisone was in both these.
Mhm.
Cortisone too,
So it depends if you're giving it PO or IV, because you can give hydrocortisone orally or IV. I know, yep, just focus on the fludrocortisone. Because the Cortef and all that, like, you will see that later. But because you can give it both IV and PO, depending on the dose that you give, if you give an IV dose, you're given like 125 milligrams. So because you're given a bigger dose, it's gonna have more effects on both the on both the glucocorticoid and the
So
mineralocorticoid.
the dosage is,
Mhm.
important on
Yes.
the glucocorticoid.
Yes, because the higher the dose, the more effects that it has and the more that's gonna affect you systemically. Lisa, you had a question?
Just to confirm, you did say taking both together, but then they had the allergy.
Correct. Okay. All right, so the adverse interactions with these medications, you have to be careful when you are giving your patient these meds. You still have to be careful about blood sugar and that kind of thing, but your biggest effects are gonna be cardiovascular related, and because it's a steroid, we're gonna worry about mental status or changes in our behavior. When you combine these meds with some of your diabetes meds, they tend not to be as effective. So that is a something that we'll talk about when we talk about diabetes meds. And so I don't want you to get hung up on the fact that this also says hypotension. So that has to do with inadequate secretion of mineralocorticoids. We're talking about if I'm giving this medication, I'm looking for a high blood pressure in my patient. I don't want you to focus on the hypotension part right now, because that's gonna be out of context with where we're at this semester. So just focus on the hypertension aspect. All right, so fludrocortisone is the drug that we're thinking about when we talk about this medication. So it is orally available, and look at the duration on that medication. So it lasts the same kind of way, like a day and a half in your patient, so that's why we just don't abruptly stop that medication. So unlike your glucocorticoids, you are going to monitor your patient's glucose level, but we're gonna be more concerned with fluid volume status on these patients. So what are some things that we're gonna teach our patient about this medication? Okay, so they could possibly be on some fluid restriction. What else?
Watch their blood pressure.
Okay, so we're monitoring blood pressure. What else?
Urine output?
Urine output, weight, very good. So how do I monitor urine output and how well somebody's doing? What do I look at?
The output?
So you look at the output, right? But what labs do I look at?
Oh.
BUN and creatinine as well. We'll talk about that more next week with BUN and creatinine. But you definitely want to pay attention to your patient's labs and their intake and output. All right, y'all, we are going to take a 10-minute break, and we will come back.